Hello, I'm delighted to be with you today. I'm Dr. Susan Taylor, the Sandra Lazarus Professor of Dermatology at the University of Pennsylvania, and it's my pleasure to discuss melanoma in people of color. I have no relevant disclosures for this particular talk. So what are our objectives? Today, we're going to discuss an overview of how melanoma affects people of color. I'm going to address misconceptions as well as myths, showcase available research, and provide practical takeaways to protect the public, patients, and your families. So what do we mean by people of color? Well, people of color corresponds to the indigenous population, certain Asian populations, the Black population, Latinx, as well as Native Hawaiian or other Pacific Islanders. There's another way in which we classify people of color, and that's based upon the Fitzpatrick skin type scale. And with the Fitzpatrick scale, we refer to people with skin of color or people of color as those who have skin types 4, 5, and 6. Now, according to Dr. Fitzpatrick, those are people who burn minimally when exposed to the sun and tan very well or deeply. So as you can see depicted on the left in this slide, it's people with brown, medium brown, dark brown, and black skin tones. So let's change our focus and discuss a little bit about the different types of melanoma, of which there are 4 types: superficial spreading melanoma, nodular melanoma, lentigo-maligna melanoma, and acrolentiginous melanoma. Now, let's start with superficial spreading melanoma. This is the most common type of melanoma. It represents 70% of all melanomas, and it's the most common type in non-people of color and young people. So those individuals with Fitzpatrick skin types 1, 2, and 3, with much lighter skin hues, and those who burn very easily and tan with difficulty or do not tan at all. Superficial spreading melanoma presents as a flat or slightly raised patch. It's irregular. There are various shades of tan, brown, blue, black, or even red, pink, or white within the lesion. And it has an asymmetric border. That means if you cut it in half, the left does not look like the right half, or if you cut it halfway through, on a horizontal plane, the top does not look the same as the bottom. And if you look at the edges, they're jagged or irregular. Those are hallmarks of superficial spreading melanoma. Now, superficial spreading melanoma commonly affects intermittently sun-exposed areas of the skin. Specifically, it occurs most commonly on the upper back of men and the lower legs of women. This is the most common type of melanoma seen in non-Hispanic whites and in some Hispanics. The next type is nodular melanoma. It's the second most common type of melanoma, representing 10 to 15% of all melanomas. The most common sites for nodular melanoma include the trunk, the head, and the neck. Now, with nodular melanomas, they are much more aggressive. They grow rapidly. They're raised above the surface of the skin. Their color is often blue-black, sometimes blue-red. You can have pink-red nodules, and 5% of nodular melanomas lack any pigment at all. This type of melanoma doesn't occur as often in people of color. The third type is lentigo-maligna melanoma. This occurs in anywhere from 4 to 15% of all melanoma patients. Now, with lentigo-maligna melanoma, it's going to occur on areas of the skin that have received a lot of sun damage, specifically the head and neck of elderly non-people of color, so elderly white patients. It begins as an irregular tan spot. It spreads peripherally, and it develops multiple shades of tan and brown. Now, lentigo-maligna melanoma can grow very slowly for a long period of time, 5 to 15 years, before becoming invasive. And finally, we have acrolentigenous melanoma. Now, this is a rather rare subtype of melanoma, and it predominantly affects the palms, the soles, the nail beds. And it's the least common type of melanoma in whites, but the most common type in Asians, in Blacks, Hispanics, and Native Americans. Now, with acrolentigenous melanoma, which occurs on the palms and soles and nail beds, it appears as a black or brown discoloration on those areas not associated with sun exposure. In the nail, it can present as a dark streak spanning the length of the nail. Now, acrolentigenous melanoma can evolve into vertical growth. That means it's going downwards. It's starting to invade. And at that point, it looks like an elevated plaque or nodule, which develops within the pigmented macule, and it can have ulceration. Not always. So really, the acrolentigenous melanoma is the one that we focus on when we think about people of color. So if we look at the rates of melanoma, they're relatively low overall for skin of color patients. So if you look at the CDC reports of the annual incidence of melanoma, we see it occurs most often in non-Hispanic whites, at 28 cases per 100,000 population. The next are the indigenous population, which have reported to have 5.6 cases per 100,000. Hispanics follow with 4.6 cases per 100,000 population. Then our Asian or Pacific Islander population at 1.3. And the least common is the Black patients at only 1 case per 100,000 population. If we look at acrolentigenous melanoma, on the other hand, and we look at various registries of melanoma, here's one that reported on 1,413 cases. And of those 1,413 cases of acrolentigenous melanoma, we see here that it occurs most commonly in African Americans at 36%, followed by Asians and Pacific Islanders at 18%, Hispanics at 9%, and least common in Caucasians at 1%. Now, acrolentigenous melanoma comprises anywhere between 4 and 58% of melanomas in people of color, and only 0.8 to 1% of melanomas in whites. So when we think about melanomas in people of color, definitely acrolentigenous melanoma occurs much more often than superficial spreading or nodular or lentigo maligna melanoma. So what do acrolentigenous melanomas look like? Well, we see here on the side of a foot a black, irregular colored, raised papule. Next, we see a very dark, a black streak in the middle of a nail, a sign of melanoma. Here we see a black macule on the palmar surface of the hand, and a very black lesion on the foot of someone with dark skin. And you can see an area of ulceration. An ulceration you can think of as a sore. So let's talk about the morbidity associated with acrolentigenous melanoma. Well, people of color are more likely to have thick lesions and have more advanced disease at the time of diagnosis. So with acrolentigenous melanoma, people with darker skin, when they come to the doctor or when a doctor identifies the acrolentigenous melanoma, it's very thick. It's at a much more advanced stage. And that means the prognosis is worse than with other melanoma patients. Now, why is this the case? Well, it's potentially due to delayed diagnosis and perhaps more aggressive behavior of acrolentigenous melanoma compared to other subtypes of melanoma. Why could there be a delay in diagnosis with these patients? Well, often people of color, be they of African or Latin or Asian descent, don't realize that they can develop melanoma, nor do they often understand the signs of what melanoma can look like. So it's often a significant delay in diagnosis, which means that the lesion can progress and become invasive. So that's going to affect the mortality of acral lentiginous melanoma. The 5 and 10-year survival rates are 80 and 67% respectively. Now, this contrasts all melanomas where a 5 and 10% survival rate is between is 91% for 5-year survival and 87% for 10-year survival. So really significantly lower survival rates for acral lentiginous melanoma. Now, the 5 and 10-year survival rates for acral lentiginous melanoma is highest for the non-Hispanic white population, okay? It's intermediate for Black populations and lowest for the Hispanic white population. So if you look at the 5-year survival for non-Hispanic whites, it's 82%. For Blacks, the 5-year survival rate is 77%. And for Hispanics, it's 72%. And finally, our Asian and Pacific Islander population, it's 70%. So you really see the disparities in the survival rate at both the 5 and 10-year period for acral lentiginous melanoma. And the bottom line is this is a melanoma that we have to take into serious consideration. So what are some of the misconceptions and myths? Now, I alluded to this already. One is that people of color are not susceptible to skin cancers. Blacks and Hispanics often perceive themselves to be at very low risk for developing these types of cancers. And they may also be less likely to seek medical care if they have a suspicious skin lesion. When comparing Hispanic and non-Hispanic whites with similar access to health care, Hispanics continue to demonstrate a lower level of melanoma awareness. So I'm here to say today that people of color, no matter what their race or ethnicity, are indeed susceptible to skin cancers, lower morbidity, and increased mortality. What's another misconception or myth? And that is people of color do not require skin exams. Now, why are total body skin examinations important? They're critically important because they allow for the early detection of skin cancers. Now, total body skin exam only increased among non-Hispanic whites despite increasing melanoma. Hispanics are 20% less likely than non-Hispanic whites to perform home total body skin exams. A study demonstrated that primarily Spanish-speaking Hispanics are 3 times less likely to report having a total body skin exam completed by a physician compared to an English-speaking Hispanic patient. So that implies there are probably some language barriers. Blacks are also less likely to have total body skin exams. In fact, Dr. Buster found that Blacks place less emphasis on the importance of regular skin examinations as a method for early detection of skin cancers than white patients did. Temashuk found that both a low level of knowledge about cutaneous melanoma prior to diagnosis and a poor understanding of melanoma treatment were both associated with greater tumor thickness. So what that means is that, or these studies emphasize, the importance of everyone, including patients with skin of color, to have total body skin exams. Now you might ask, what is a total body skin exam? That's an examination when you see a dermatologist and you remove all of your clothing. And the dermatologist will look at your back, your buttocks, the back of your legs, your neck, your chest, your abdomen, the front of your legs, your front and back of your arms, under your arms, your face, your scalp, your ears. In fact, the dermatologist will examine your fingers, your toes, in between your fingers and toes, your palms and your soles. So your complete body, all of the skin on your body. And what is he or she looking for? We are looking for an unusual mole, a black or unusual spot, one that's irregular or asymmetric, and that can be a clue to melanoma skin cancer. Let's say we do see an area that's suspicious. What will we then do? We will perform a biopsy, give you numbing medicine, remove it, maybe a stitch, maybe not a stitch, send it to the laboratory when we can identify whether this lesion is melanoma or not. Let's go back to our misconceptions and myths. Well, another is that people of color do not need sun protection. Overall, there's very low use of photoprotection with people of color. In terms of photoprotection, we mean all measures: sunscreens, hats, seeking shades, wearing sunglasses, for example. Various studies have found that sunscreen use is highest among non-Hispanic whites, lower among Hispanics, and the lowest among Blacks. A second study showed that, again, sunscreen use was highest among non-Hispanic whites, then Asians, followed by Hispanics, and the lowest with Blacks. So this is a significant problem and really a gap in education, that all people of color must be taught that sun protection is critically important. Another myth is that people of color are aware and educated regarding melanoma. In many cases, they are not. Now, compared with non-Hispanic whites, both Hispanics and Blacks appear to be less knowledgeable about melanoma. In fact, Dr. Sanchez demonstrated that 86% of people with Fitzpatrick skin types 1, 2, and 3, those are people with very pale, very white skin, were able to successfully identify melanoma as a cancer, whereas only 46% with medium brown skin were able to successfully identify melanoma as a cancer, and 57% of those with the darkest skin were able to successfully make that diagnosis. So here we have gaps in awareness and gaps with education and identification of melanoma. So when you think about information that's critically important for you to know and for you to disseminate to family and friends, it is as follows. Skin cancers can occur in anyone, despite their race, gender, or ethnicity. It's important to be proactive in prevention and detection. How do you do that? Well, you can examine your own body, all areas, including feet and hands and nails and inside the mouth and the genital area, as well as the rest of your skin. It's important for people of color to pay particular attention to fingernails and toenails, which may be covered by nail polish, and to look for a dark streak. It's very important to let all of those that you love and know to see a dermatologist yearly for a total body skin exam. Don't forget, remove your shoes and socks. Make sure the dermatologist examines the soles of your feet to examine your nails, your toenails, and between your toes. Make sure you see a doctor immediately for a new growth or for a new or changing mole. And photo protection every day is critically important for every type of skin. Now, I'm going to just turn my attention for 1 minute to talk about some of the new research. There have been significant breakthroughs in new treatments for melanoma. And there are many medications or drugs that target melanoma cells that make them different from normal cells. And these new targeted therapies work differently from standardized chemotherapy. And that's where a lot of research is occurring. Clinical trials now testing certain drugs. You've heard of Gleevec, for example, which target cells that change certain genes in cells that are responsible for the transformation into melanoma. So much research is going into drugs that target various cells and sort of block the formation of melanoma cells. Or they target genes or proteins. And so we're looking at and investigating those types of medications. There are also a whole host of immunotherapies. You've heard a lot about immunotherapies that can shrink melanoma tumors. A lot of research at that. And something called immune checkpoint inhibitors. And these are newer drugs. You probably heard advertisements for Keytruda. And they block proteins that normally suppress the immune response against a melanoma cells. So a lot of research going into new and effective target therapies and immune therapies for the treatment of melanoma. So it is absolutely amazing at the progress that we have made with the detection of melanoma as well as with the treatment of melanoma. So I want to thank you for your time and your attention.
Thank you, Dr. Taylor, for a great talk. I'd now like to introduce Ginny Kanwa Onyekaba, who will be answering questions on behalf of Dr. Taylor, who's unable to be with us this afternoon. Ginny Kanwa Onyekaba is a fourth-year medical student at the University of Pennsylvania. She attended Duke University for her undergraduate training and spent 1 year at the National Institutes of Health conducting research before she matriculated at Penn for medical school. Ginny Kanwa had the opportunity to work alongside Dr. Taylor on research focused on acral lentiginous melanoma and looks forward to answering any questions that you might have about melanoma and skin of color. We'd now like to take questions. If you have a question, please submit it using the Q&A toggle on the right side of your screen. First, I'd like to thank you for joining us. I really appreciate you stepping in. I know you have a really difficult clinical schedule and have a lot going on. So thank you on behalf of all of MRA for joining us.
Of course, and thank you for having me. I'm happy to be here, and I'm happy to answer these questions.
Thanks. And I'd like to just start off, just kind of getting us moving with a probably an easy question. But from your experience, what is the most pervasive myth that exists about melanoma among people of color?
I would say that the most pervasive myth that exists is really that patients with skin of color are immune to melanoma. This myth has kind of been perpetuated for many years, and it's for this reason that a lot of these patients don't actually present to dermatologists for their regular skin checks. And when they do get melanoma, it tends to be diagnosed at a much later stage. It tends to lead to much worse outcomes because, the melanoma at a later stage tends to be much more aggressive. It metastasizes to different parts of the body. So if these patients aren't going to dermatologists to get checked, how are you going to identify the melanoma and treat it appropriately? Because again, early detection is key. So I'd say that's a very pervasive myth and something that we need to combat every single day to keep patients healthy and happy.
Yeah. And one of the things that Dr. Taylor mentioned was that when it comes to people of color, we're really not talking about these cutaneous melanomas, which are really driven by UV rays. We're really talking about acral melanomas. Is that right?
Yes, that is right. Exactly. Although patients with skin of color tend to get melanomas at a much lower rate, when they do get melanomas, I think the statistics was about 80% of those melanomas tend to be of the acral lentiginous subtype, which is actually the melanoma type that killed Bob Marley. So it's definitely very pervasive among patients with skin of color.
Acral melanoma, we don't know what causes it. Is that right? Like it's not.
Yeah, we still don't know exactly what causes it. It has been hypothesized that it could be due to trauma. It could be due to a higher predisposition for the cells in the acral location, so within the palms and the soles of the feet. We actually did a study on this, but we were looking at the cells in African Americans versus Caucasian women, and we did find that the cells in African Americans had a higher likelihood of proliferating, of multiplying. And when that you have a higher likelihood of multiplying, you actually have a higher likelihood of getting mutations. And the more likely that you are to get mutations, the more likely they are to become cancerous. So that was an interesting finding that we did find in our study. Yeah, but still, honestly, the cause is not known. And there's still a lot of research around that at this time.
Yeah. So thank you for doing some of that important work. It also really relates to another question that we received, which is, if acral melanoma isn't caused by the sun, why are we so worried about sunscreen still?
Yeah, so even though acral melanoma isn't caused by the sun, sunscreen is still important in all patients, regardless of whether you have darker skin or lighter skin. But patients with lighter skin have a much higher predisposition of getting cutaneous melanoma and therefore needing sunscreen. It's one of those things where it's better safe than sorry. Like, what does it really hurt to put on sunscreen? What does it cause you? Like, what's the cost versus what are the potential implications? And although cutaneous melanoma is very rare in skin of color, it still does happen. And so sunscreen is still combating that every single day.
Others are also prevented by using sunscreen, and things like photo aging and even sunburn. Like, who wants a sunburn?
Oh, that's true. Yeah, exactly. Sunburns. I could live my life without them.
Right? We could go back in time. We've also seen that there is a lot of debate on the idea of over biopsying, meaning that too many lesions are being removed that did not need to be. Can you talk at all about this kind of debate as it relates to skin of color and melanoma?
Yeah, I do wonder with that debate, what's interesting about the debate is that it has such little to do with skin of color, because a lot of these patients aren't even presenting to the dermatologist to have their skin checked, to have that biopsy done. So my first question was, the thing I thought of is there probably under biopsying among patients with skin of color? Are they even presenting for their full skin checkups? Are they being cautious enough to kind of appreciate the fact that, again, we are not immune to melanoma. Acrolitiginous melanoma does exist. And so we have to still be very, very careful. And by being careful, that means going to the dermatologist and getting checked up. So I understand over biopsying does happen, but I do think with skin of color, it's more of a debate of, are we even being biopsied to begin with?
Yeah,
and are we checking it? Yeah. Because it is, again, I do believe the fact that when we catch melanoma, it's at later stages, it's much more aggressive, and it tends to have much worse outcomes. I think it's because no one is getting that biopsy earlier on. They're only getting it when it looks very, when it looks much worse, when it's very clear that this is not normal. But I think by checking it when it looks maybe not particularly normal, but when it looks not so bad, would be the best steps to take.
Right. And then do you have any recommendations on what patients or people can look for to find a dermatologist who is really equipped to treat people of color well?
Yeah, I guess that's a little bit tough. And I think that's something that I would have to defer to Dr. Taylor to answer that question, but I know she's not with us. So I'll definitely get back to you on that question. The one thing that I do think of is that maybe finding a dermatologist with skin of color, and I know that's very rare these days still, but that would be the first step that I would try to take. And the next step would be there are resources around that even educate patients. I can't think of what these resources are called right now, but there are resources that are actually targeted at patients with skin of color, so that we can be better advocates for ourselves if we are in a dermatologist's office who doesn't seem to know what certain skin types look like on skin of color. So I think the next best step would be to go to a dermatologist, become very educated, come prepared to advocate for yourself. Don't just listen, also speak up.
I love that. Yeah. Sometimes it really requires you to be your own best advocate. Yeah.
Yeah.
And I have just one more question, and that is, what can we as advocates, there's a lot of advocates on this call. There's a lot of melanoma organizations represented on this call. What can we do to make sure that our awareness campaigns, our information is serving all people, regardless of skin tone?
I think one thing that I think of is the importance of being able to share these resources amongst not just the patients, but also making sure that patients are informing their family members, their friends, kind of making sure that information being distributed, the best way for it to be distributed is by word of mouth, right? Not just these targeted programs that are very good for fighting like misconceptions and informing, but also once you are informed, kind of spread that information. Something like these misconceptions, the myth about sunscreen, the myth about, melanoma not being present in patients with skin of color. These are all myths that the more we keep this conversation alive, the better it'll be in the long run for everyone involved. And that's not just us as educators, but it's also us as, sisters, as wives, as children. So it's just, yeah, that's what I think.
It's important. Like we say that all the time. So you want to take care of yourself and those that you love. And those are people who, your family, your friends, the people around you. Hey, if you have something that concerns you, get it checked out. Yeah.
Exactly.
Well, I'd like to thank you again for joining us this afternoon. This has been really an interesting conversation, and I really appreciate your insight. Do you have anything that you want to leave the audience with? And I'll be sure we reconnect about those follow-up items and make sure we get those up to folks.
Yeah, I think the last thing that I'd just like to leave the audience with is just with an appreciation of how important it is to be here, how thankful we all are that you showed up today, that you wanted to learn more about, what melanoma means. What does the research say? What are the most recent findings? The fact that it's a Thursday evening, and I know that everyone's kind of busy these days. So just showing up here is such an important step. And I thank you for being here and joining us this evening.
Thank you. That's great. Thanks again.
Yeah.